Okay, we're going to cover COPD next. Everybody with me? Okay, let's talk about the pure definitions of COPD. The American Thoracic Society back in '95 defined COPD as a disease characterized by the presence of airflow obstruction due to chronic bronchitis or emphysema. The airflow obstruction is typically generally progressive, may be accompanied by an airway hyperactivity of the asthmatic component, may be partially reversible. GOLD, the International Initiative for COPD, defines it as a disease state characterized by airflow limitation that is not fully reversible. Airflow limitation, usually both progressive and associated with an abnormal inflammatory response to the lungs, to noxious particles or gases. Let's talk about the clinical categories of COPD. Most common diagnoses for COPD are emphysema, chronic bronchitis, asthma, bronchiectasis, and small airway disease. COPD often begins as emphysema or chronic bronchitis. Causes are usually due to the environment, which we relate to again the kind of work you do, like somebody works in a coal mine or steel worker, etc. Lots can be due to lifestyle, poor habits like smoking. Now again, emphysema and bronchitis usually a very similar progression as far as disease state and damage to the lungs are concerned. Patient is diagnosed with one lung disease like emphysema bronchitis. After many years, it may be very difficult to determine what's the primary disease state. And a patient has one disease is likely to have another disease in the same category as COPD as well. As an example, someone with bronchitis may also be diagnosed with bronchiectasis as an example. Bronchiectasis is an abnormal widening of the airways, which often leads to chronic infection, pneumonia. So let's talk about the common pathology. For both bronchitis and emphysema, both have a decreased ability to provide to move air in and out of the lungs or to ventilate normally. In both cases, damaged lung tissue results in decreased oxygen intake and carbon dioxide output. So let's talk about bronchitis first. With chronic bronchitis, usually you have chronic inflammatory process of the lungs, which also results in a chronic hyperactivity and mucus production. With emphysema, what you end up having is a loss of tissue elasticity. And you see the lung tissue, specifically that of the alveoli, start to break down. They inflate, become overinflated, and do not contract normally, which causes air trapping. So let's give you examples of both patients. As an example, if you look at this patient with emphysema, there's a few things about him. So again, to go back, emphysema involves destruction of lung tissue responsible for gas exchange. We lose surface area, primarily the alveolar walls where gas exchange takes place. We lose tissue elasticity. That loss of tissue elasticity results in the lungs to remain expanded and lose contractibility. And because of that loss of contractility, the lungs that remain expanded, the thorax actually changes shape. So because you see that barrel shape sort of take place. And because of that, the diaphragm doesn't work normally. So you see the patient start using extrathoracic muscles, or accessory muscles to affect the work of breathing. And because of that use of extrathoracic muscles, we start seeing almost constant dyspnea, increased work of breathing. Now with emphysema, there's very little sputum production. We also know that these patients have pink puffers. Because of the increased work of breathing, you'll notice that the cheeks become very pink or rosy. Now again, our pink puffers are emphysema patients typically experience dramatic weight loss. Anybody want to guess why? Because of the increased work of breathing, which is almost constant, they burn a lot more calories. Also, something we don't think about is the act of eating and drinking. Because these patients increase work of breathing, they tend to aspirate more. So because of that, the act of breathing and eating don't work hand in hand very well anymore. So every time they take a drink or try to swallow, they end up aspirating, coughing. So again, that because of that lack of intake, you start seeing them dramatically losing weight. So again, also they experience because of the increased lack of ability to lungs to contract, they trap air. So again, you see that change in the shape of the thorax, that barrel chest begin to occur. Most of our emphysema patients typically have been smokers historically. So that fits the profile. They're always short of breath. They breathe through pursed lips, causing that rosy cheek, that pink puffer look to occur. They also have frequent wheezing and coughing. You also see our emphysema patients tend to go in that tripod position. You'll see them bend at the waist, use work of breathing. It's not uncommon to see them again with their elbows on their knees leaning forward, or if they have bedside table, leaning forward to the bedside table. Again, causing that, the extrathoracic muscles to expand more, it's just the anterior. And they also may be prone to frequent infections. Because of that air trapping, the diaphragm doesn't drop normally, so the ability to cough and clear effectively, even if they don't have, frequent or excess secretions like a bronchitic patient. As I mentioned, the work of breathing causes them to do a lot more when they eat or drink, aspirate, so they're not able to clear. That secretion, the aspiration may cause, again, them prone to develop infections. So again, you have to watch for that. So let's go to our bronchitic patient. Bronchitis is defined by, or characterized by chronic cough and producing sputum for at least 3 consecutive months for 2 consecutive years. They have copious amounts of sputum production and cough due to the increased inflammation of the airways and chronic sputum production. So you can define chronic bronchitis by a couple different categories. Simple chronic bronchitis is when you have productive cough, but does not have a chronic airway obstruction. So they can still get air in and out, pretty effective. But again, that constant sputum production causes that chronic cough. You have that chronic asthmatic bronchitis. You have periods of asthma-like wheezing. And then you have that obstructive chronic bronchitis. We have that consistent wheezing and obstruction. So on top of that chronic excessive production of mucus in the airways and their constant coughing, then you have that hyperactive airway, which brings in the asthmatic component. Now, they may have mild dyspnea, meaning they're mildly short of breath, because again, unlike the emphysema patient where they have, loss of tissue elasticity, they can bring air in pretty effectively, and they can expel air, so they don't have air trapping. So the diaphragm still works fairly normally, but because of the chronic inflammation of the airway, it is still difficult to get air in and out without extra work. And the coughing causes, excessive coughing and secretions causes, of course, obstruction as well. Now with my bronchitic patients, no progressive CO2 retention. You'll see cyanotic lips, typically worse at night. Why at night? Because we tend to hypoventilate at night. They have frequent respiratory infections, again because of the excessive secretion production, mucus production, and the ability to clear effectively. Their secretions tend to settle on the bases. You'll see a lot more pneumonia occur in these patients. We call them blue bloaters. Anybody want to guess why? My bronchitic patients are typically, they appear obese, and they also have hypoxia. So you see a lot more cyanosis in those patients, in the extremities, in the fingernail and nail beds, lips. They would typically have a large midsection, and weight loss is very difficult. Now, weight loss is difficult in these patients for the opposite reason of my emphysema patients. With my bronchitic patients, because of the increased work of breathing, because of the hypoxia, and because, again, on exertion, they tend to get typically become hypoxic. The ability to, if their weight gain is due to excessive overeating or natural obesity due to, again, more intake calories, the ability to, again, participate in aerobic exercise is very difficult, right? So again, losing weight is not easy for them. Also, because of bronchitis, one of the primary treatments for somebody with bronchitis and with chronic inflammation of the airways is what? Steroids. So with the steroids, what do we typically see? Weight gain, right? So again, that can also be a problem with my bronchitic patients. And keep in mind too, some of my COVID patients, you're going to see the fitness profile as well sometimes. Again, for all the same reasons. Again, because COVID is primarily an inflammatory disease process or disease state. So you're going to see again some secretions. You're also going to see again that look of weight gain, which may be related to steroid use as well. Also, because of steroid use, something else to keep in mind is you may see issues like thrush. Everybody familiar with thrush? The upper airway. So make sure as well with when you start seeing that thrush occur, there's also cause other upper airway issues, which also is going to cause issues with the lower airway. And a hyperactive response, which is going to kick in that asthmatic component. Make sure that you're watching for the series of thrush. Okay? Now again, with thrush, you're going to see treatments like diflucan. Everybody familiar with diflucan? And then of course your nystatin mouthwash. So keep that in mind. Okay, so additional details for bronchitis. You're going to have a narrowed airway, again leading to obstruction, difficult to get air in and out. The inflamed lung tissue is going to cause again excessive secretion, mucus production. And so the mucociliary elevators are not going to work effectively with our bronchitic patients because of the excessive secretions and inflammation. So that natural action of bringing secretions up, the mucociliary elevators can be impaired due to the inflammatory process. Secretion, expiration or coughing, mobilized secretion will be much more difficult. So let's compare our two patients. So emphysema patients are typically going to not have as many secretions, so that bronchitic component's not going to be present, but they're going to have barrel chest, right? Why do they have barrel chest? Anybody remember why? Because of air trapping. Remember the lung tissue loses elasticity, so the ability to help, again, that air to be pressed out or pushed out during the expiratory phase of breathing. It's going to cause air trapping. This will cause the thrush to change shape. Then they're going to have dyspnea early, so they're going to be working to breathe early in the emphysema process. You're going to see them hunched over. Typically, you're going to see them in that tripod position, leaning forward. Again, allowing for additional expansion of the basal segments, the lung segments, and allowing for the intercostal muscles to expand the thorax more, especially in the basilar segments anteriorly. You're going to see them hyperventilate. So typically, my emphysema patients are going to be breathing very rapidly, very frequently. So again, and that's going to result in increased what? Right. So again, now my emphysema patients may actually oxygenate better than my bronchitic patients. So that you're not going to see them be as cyanotic, typically. Again, we mentioned weight loss. What's your name? Kathy? Thanks for remembering that, Kathy. So again, weight loss is critical. Nothing worse than not building that I've walked in a COPD program in the last 35 years. I've been doing this for a long time, since the 80s. That I've not found somebody with emphysema literally starving to death in the building. Nothing worse than seeing that patient that wants to eat, swallows food, but can't eat because every time they eat, they aspirate. So keep in mind, you're the cops on the beat. You make sure that those patients, you're watching very carefully when they're pushing their trays back, being picked up, and again, nothing's been eaten, they're not drinking enough. And again, so make sure that you're being aware of that. That patient's going to be, again, prone to weight loss and compromise very, very quickly. Now for my bronchitic patients, again, that bronchitic component is primarily what? Increased what production? Mucus production, right? Now, do they have an issue with air trapping? No, so you're not going to have that barrel chest, correct? Okay, good. Now again, unlike my emphysema patients, they're not going to, this is going to be much later in the process of the disease state. Now they're going to actually experience dyspnea or shortness of breath again upon exertion. So they're not going to have that air hunger, just sitting in a chair at rest, or with a normal, again, mild or moderate activity. So their ventilation, the ability to bring air in and out, is usually okay. So it's the active respiration, exchanging gases, that's really impaired with my bronchitic patients. The ability to uptake O2 and blow off CO2 effectively. So you're going to see them be the ones that are primarily cyanotic. My bronchitic patients, and in case you need to remember what they look like, my bobs, right? My bronchitic bob here. You're going to see him be cyanotic more often than not. So you're going to see, again, cyanosis in the lower extremities, nail beds, their lips. You're going to see right-sided heart failure be very, could be another comorbidity that you recognize this patient, which also affects their ability to exercise and lose weight, because again, aerobic activity is very difficult for them. And again, they're going to appear obese. And again, that obesity, again, is related to two things. One, their inability to burn off calories, because aerobic exercise is very difficult for them. And second, again, could be because the treatment for a bronchitic patient typically involves some sort of routine steroid use, especially if they're in an acute phase. My COPD patient with bronchitis that exacerbates, one of the first things your primary physician is going to be ordering is going to be probably oral steroids, usually 1 to 4 milligrams per kilogram. So there's going to be a high dose for them, especially in this setting. So again, that's going to make them even more sedentary, and then it's going to again cause them to probably again appear to gain weight, and going to increase their hunger, and again their ability to exercise is still going to be impaired. So again, it's not going to, so it'll be very difficult for them to mobilize. Any questions on emphysema and bronchitis? Let's talk about asthma. Any asthmatics in here? Mary, okay, good. We've got one. Now, when did you discover you had asthma? As a kid?
No, actually, as an onset as an adult.
Okay, really? Do you know why yet? Have they diagnosed why asthma? Typically, the asthmatics have two, they're defined really in two categories, intrinsic or extrinsic. Intrinsic means something that's internal that's going on. I'm sure you've seen the commercials for eosinophils. Okay, again, I think it's Fasenra is the drug of choice right now. So again, you got excess production of a specific type of white blood cell, eosinophils in the lung, that causes that intrinsic asthmatic effect. So again, Fasenra helps inhibit that white blood cell production, specifically to, again, an asthmatic. So that's an intrinsic asthmatic. Extrinsic means environmental, meaning that you have a response to allergens or noxious particles in the environment. So again, in this environment, typically with the asthmatic component, you're going to see it's something in the air or in the environment for our patients that sets them off. So again, that's going to be that Bob or that my bronchitis patient or my emphysema patient that you're waxing the floors in the middle of the day or you're disinfecting the room and has that strong noxious scent, it's going to set them off, right? Okay, so again, you've got to watch those things. That's why again with the mask, we're talking about the BiPAP CPAP mask, cleaning with something, a mild detergent, non-scented, because that scent's going to set them off if they have an asthmatic component tied to their COPD. And typically the exacerbation is tied to the asthmatic component of COPD. Now again, with my bronchitis patients specifically, that asthmatic response is going to cause an increase in mucus production, which also is going to again cause compromise. Now you're going to see it again characterized by wheezing, shortness of breath, and typically a cough. Now, the good thing about asthma, it's almost completely reversible with our bronchodilator or beta-2 agonist. So you have that exacerbation, then that remission without progression, typically in most patients. But now 30% of my COPD patients that have an asthmatic component typically have this. So about 30% of my COPD patients typically have a severe asthmatic component. That's the ones that you see those frequent flyers that go out because of that exacerbation. But now that can be managed very, very effectively in this environment. Typically it's for having that emergency inhaler or that emergency pure neb when they exacerbate, as an example, or for a really bad COPD is that standing order for a steroid. And to reduce what? Steroids usually do to reduce what? Inflammation, right? You'll see a combination of, again, my beta-2 agonist, my albuterol preventol, typically, in those patients, for emergency use, when they have that exacerbation. And that's, you'll see that about 30 of your patients, typically, in this environment. Whoops. Let's talk about quality of life with COPD. As COPD progresses, as my shortness of breath worsens in both categories of emphysema and bronchitis, the ability to exercise is severely limited. And the quality of what exercise they can do, again, is usually very poor. You're going to see a lack of participation in their ADLs. That's usually why a lot of my COPD patients end up in a nursing home environment. It's because, again, they're not able to take care of themselves at home as it gets worse. So they need that extra assistance. The ability to interact socially is very impaired. So, that's going to lead to another psychological impact we'll talk about in a minute. Again, imagine if you have emphysema. As I mentioned before, that patient with emphysema, typically they hyperventilate, correct? So when you're trying to breathe 40 times a minute, what's it hard to do? Talk, right? So again, my patient with emphysema is not going to be having a conversation with you. If the answers are statistically very short, direct answers very quickly. Now my patient with bronchitis, why is that going to be difficult? They're coughing frequently, they have lots of secretions. So again, them carrying on conversations on Taco Tuesday, it's not going to be at the common dining, it's not going to be something they do. Yeah. So again, social interaction is very difficult. So again, because of the impact of COPD and their ability to communicate and interact socially, things can also, in their ability to participate in ADLs or exercise, do things they used to doing when they were healthy. You can see depression, fear, anxiety, and embarrassment. Why depression? Think about it, because a lot of my COPD patients typically have been very active people. They've been hard workers, typically blue collar. They've had jobs like we've had in healthcare as nurses, RTs, CNAs. They've worked in a steel mill, car factory, coal mine, farmers, etc. So again, not doing the job I used to be able to do, and now look at me, I've got emphysema and I've lost 50 pounds. I'm a shadow of my former self. Fear, because why? Because I can't breathe. Imagine drowning in your own secretions every day. It's somebody's bronchitis. You can't clear at all. No matter how hard you cough, no matter how hard you work to mobilize secretions, you just sit there drowning your secretions. So again, anxiety. Why anxiety? Because again, every time I move, trying to get up by myself to go to the bathroom for my ADLs, dress, I get short of breath, I get hypoxic, I get dizzy, I fall over, I need assistance. Embarrassment. So again, used to be a healthy adult, now I need somebody to help me go to the bathroom, help me bathe myself, help me clean. So again, embarrassment of my current physical condition could be, again. So my COPD patients, again, the biggest impact for them, beyond the physiological impact, the things that are obvious, again, is the emotional and psychological impact. So I can't emphasize enough to you the importance of the holistic approach to your COPD patients. Now you're going to see a lot of this. If COVID has taught us anything in the last year, comorbidities matter. Because all my COVID patients have been COPD patients. Again, everything that was probably before is now amplified 10 times. So again, keep in mind anything that was bad before was COPD, and you're going to be seeing a lot of COVID patients that are going to be referred to your facilities with these programs. That again, their treatment and any progress they made in managing their COPD has been halted, and even they've lost some of the progress they made. So again, everything I'm mentioning to you now is things you're going to be rebuilding from scratch on. And again, malnutrition, especially by COVID patients that had emphysema, because they were working hard to breathe before, now they're working even harder because they've lost ground. So again, malnutrition is going to be something that's even more of something to watch. Because again, just with my normal emphysema patient, 15% of the caloric intake daily, which is just the work of breathing. So now with post-COVID, emphysema patient, even more of the caloric intake is going to go to that work of breathing. Because again, I'm even more impaired now than I was. So without that ability to bring enough protein, and again, working on muscles aggressively now, not just my diaphragm, but now all these interthoracic muscles, intercostals. Again, you're going to see a lot more wasting away muscles. So again, not just the thoracic musculature, but again, the extremities. All my bulk muscles are going to start breaking down. Why? Because I'm feeding all the other muscles that are. So I'm going to be eating up my musculature of the entire body. Hypercapnia, you're going to see again my bronchitis patients that tend to retain CO2 even more. You're going to see again increased CO2 retention. you're going to see, again, even more psychological impact, more depression. And again, you can see more impaired ability to exercise, especially in my post-COVID patients with COPD. So before I move forward, any more questions on quality of life impact? Okay, again, so let's wrap this up for you. Again, dehydration, fluid loss through labored breathing. So again, we all know that, again, the natural humidification process is our nasopharynx, oropharynx. So as we breathe in air, we take in natural humidity from the air, burn to humidify, again, to the mucosa, the air that's coming into our body. So if I'm breathing rapidly, and I'm drawing the mucosa, that normal humidification process is bypassed. It doesn't work as effectively. On top of that, if I have emphysema and I can't get enough fluid intake, mucosa is going to dry out. And so that humidification is already impaired again, right? It's important that we make sure our patients have enough to drink, so that, again, that humidification process is not impaired. Again, and then impaired humidification process, dehydration. Like I said, it's due to a lack of inability to, again, intake enough fluids because I tend to aspirate. So again, sleep. Somatic issues are very prevalent in my COPD patients. So you see a lack of, you see a frequency of insomnia. Because again, if I have emphysema, I'm working hard to breathe 24/7. If I have bronchitis, I'm also working hard to breathe because, again, why? I have that obstruction, increased secretions, I'm coughing, so again, I'm always struggling to breathe. So with insomnia, there's a lot more issues with daytime sleepiness. So you're going to see that patient that's always, nodding off in the middle of the day. You're going to see that patient that also has a fear of apnea. Another reason why he's sleep deprived, because when I go to sleep, I tend to quit breathing. Those patients with those issues with sleep deprivation and obstructive sleep apnea, you're going to see also have orders for CPAP and BiPAP as well, typically. And keep in mind with the RT, you're going to see a lot more orders. If we notice that as RTs and we're assessing these patients, we may be actually acting as a physician for orders in this environment for a sleep study, and you bring, again, BiPAP or CPAP in to help with that. All right, so other indicators that may, again, show the impact of COPD and the quality of life. Fractures, frequent falls. Why fractures? Anyone hazard a guess? What was that? Well, actually more simpler than that. Because then that goes back to dietary requirements, right? Right, so if I get hypoxic, I get dizzy when I stand up, I'm short of breath, and I will fall, all right? So again, a lot of patients that, again, get referred to this environment from home, could be because they broke a hip. COPD is just a comorbidity that's mentioned. How they broke the hip? Maybe they broke the hip getting up at 2 a.m. to go to the bathroom. They became hypoxic and fell. So again, depression, we talked about depression, right? Okay, multiple meds. So again, because again, my patient with COPD may be on, again, steroids, anticholinergics, again, multitude of inhaled drugs. Cognitive impairment, why? Well, I guess cognitive impairment, what impacts your cognition? That's pulmonary related. Oxygen, right. What else? Anybody ever hear of CO2 narcosis? Okay, so let's start with the hypoxia. So again, if I have a drop in oxygen in the bloodstream is severe, again, I become obtundant, right? May be confused, not make any sense. All right, so if I have CO2 narcosis, we see the same thing. So again, with elevated CO2 in the bloodstream, it also comes like a narcotic. Same thing. So again, incontinence. Why incontinence? Why would you think my COPD patient would be incontinent at night?
Because they can't get up and
Right. Going to the bathroom, again, another ADL issue, right? They can't get up, go to the bathroom, so what do? I know I'm going to get up, I'm going to fall, so I'm not going to get up. Right, so again, let's say that, how many of you are charge nurses here? or supervisors or unit managers at night or during the day. All right, so again, if I see Nate come and said, hey, you know what, Bob is, his bed is wet again today, 5 days in a row. So again, if he's on an oxygen, he's a COPD patient, I'm going to go back and assess Bob and say, hey, you know, what's the issue, Bob? This is not usual for you. This is something different. Again, Bob's embarrassed. Again, we talked about, again, the way I see myself, right? Okay, so again, Bob, why can't I get up at night? Why can't you get up at night? Why are we having these access for? For something very simple. My oxygen tube is not long enough. I got to get up and I can't go to the bathroom without the oxygen, so I'm afraid to get up, so I'm having access. So again, you have to investigate these things. Incontinence is something that's, again, a side effect, unfortunately, in this environment, because of my self-image, I may not be willing to share that with you easily or openly. Again, you have to investigate these things. These are some things that are easy to fix in this environment. So incontinence, any questions about incontinence in my COPD patients? How about weight loss? We talked about weight loss, didn't we? Okay, again, please watch this page. Nothing more frustrating to me as an RT in 35 years in the industry than seeing somebody starving to death when they could be eating. So please watch weight loss in your COPD patients. Bed fast. Again, it goes back to my incontinence issue. Why am I bed fast? Because again, I just need assistance with oxygen. Need to be taught by my rehab team how to plan and pace accordingly to get out of bed, mobilize in the hall, without getting dyspneic. Learning how to personally breathe, learning how to manage my oxygen from a portable standpoint. Okay, late loss ADLs. Again, the patient that was admitted last week would bathe themselves, or at least assist me in bathing them. Now, they're not. Back to incontinence. A week ago, my patient could get up 2 weeks ago, last month when they were admitted. Now, the long term, they could at least get up and go to the bathroom on their own. Now they can't. So again, seeing the steady loss of ADLs progress. Again, you're the cops on the beat. You're the one to see these patients every day in the 24-hour cycle for long durations of time, days, weeks, months, sometimes years. So you notice these cycles of these patients. You notice there's a change. That late loss ADLs is something you should easily be able to pick up on. Again, anti-anxiety and hypnotic drug use. So again, one of the worst things I see as an RT is the use of Ativan in these patients with COPD. A lot of times we mask the real issue. Bob's anxious. Bob's anxious why? Because he can't breathe. What can I do to resolve that anxiety that involves, ordering, a hypnotic or a sedative? So again, it's about, identifying and looking at the patient from a holistic standpoint. Look at the entire patient. Anxiety can be measured in anxiety can be managed in a lot of different ways other than a drug. From a quality of life standpoint, my COPD patients, again, if their COPD is advanced, and a lot of things we see here, we've talked about happening, coming to, again, participate in activities for leisure, or just to, again, keep them moving and active in the community, in this community, may be very difficult. It also goes back to self-image and the psychological aspects of the COPD process. So if you see little or no activity on my COPD patients, you have to ask yourself why. What can I do to change it? Any questions about impact or quality of life? So if I go back and talk about weight loss, what are you going to look for with weight loss? Give me 2 things you can watch. Aspiration, right. And for something simple that we do, what do we do 3 times a day with our patients? Meals, right? All right, now do you document how much they eat? Do you ask your CNAs? All right, so again, if I notice a tray, if I'm documenting a tray, so pushed back, again, all week long, they're not eating their breakfast, not eating their lunch, or eating just a small amount, and I notice they're losing weight when I'm doing their daily weight checks. Is that going to be a red flag for me? Yes, right? Okay. Let's talk about the final results of COPD. First, for muscle fatigue. Eventually, they're going to wear out, right? Cardiovascular deconditioning. Again, we talked about core pulmonale earlier, right side heart failure. So eventually, again, if I'm working hard to breathe every day, if I can't exchange gases, I'm starving the body of oxygen, what's going to happen to my pump eventually? The pump's going to do what? Go fail eventually, right? So again, poor posture. In my COPD patients, you're going to see a couple different things. My emphysema patients, you're going to see them in that tripod position very frequently, right? Leaning forward, elbows on knees. working to breathe, right? Okay. My bronchitis patients, you're going to see almost the same thing. They're going to be slumped over, poor posture, around the shoulders, forward head. And they're going to see that, again, that's to get those anterior accessory muscles to help expand the thorax to get more air in. Death from COPD is usually associated with a combination of hypoxia, acidosis, and right side heart failure. What's the most terminal event? Pneumonia. Now, with all my COPD patients, pneumonia is usually the terminal event, especially my bronchitis patients. Why? Because of excess secretions, right? Inability to clear them. Any questions about the final results of COPD? Let's talk about management goals. When a patient's admitted with COPD or related diagnosis, there's goals that as an interdisciplinary care team we're trying to achieve. Primarily for our sake and their sake, reduce frequency and duration of hospitalizations. Reduce anxiety and depression. Reduce issues with sleep. Improve self-esteem. I can't emphasize enough that, again, self-esteem and reducing levels of anxiety and depression impact everything else here we're talking about. When you can impact psychological aspects of COPD, you have a tremendous impact on the physiological aspects of COPD. All right, so again, all that, again, helps slow the rate of deterioration of pulmonary function. Improving exercise tolerance. Increase longevity. Reduce fatigue and related to pulmonary muscle fatigue. Improve tolerance of ADLs. Improve performance of ADLs. If I reduce shortness of breath in bathing or toileting, dressing, the performance is going to improve, right? Means more self-management, less workload on the nursing staff. More likelihood they're going to transition from this environment back to home, which is ultimately the goal. Conserve energy. Again, that's where my rehab team comes into play, assisted by OTs, and teach them how to plan a pace when they're dressing, when they're walking, ambulating. Again, increasing capacity to work and increase work efficiency. Improve performance and reduce fatigue-related pulmonary function during physical or occupational therapy. Manage dyspnea during exertion. And again, with my rehab team and ultimately with you, again, using diaphragmatic retraining, personal breathing, reduce internal muscle fatigue, manage dyspnea during ADLs, decrease excessive work of breathing, capacity to work, improve cough effort. All these are goals of our COPD management. Any questions about any of these and how to achieve those goals? Okay, we talked about treatment categories. Okay. Yeah, we mentioned our emergency inhalers before, right? Emergency PRN nebs. Those typically fall under our bronchodilators, our beta-2 agonists. That's our first line treatment. Again, short-acting bronchodilators like albuterol. Those really are our PRN drugs, our emergency use, right? Okay, again, our antimuscarinic agents we typically call anticholinergics, historically. Those help. Those drop the bronchoconstrictor effect. What anticholinergic does, it inhibits a neurotransmitter acetylcholine, which causes bronchoconstriction in the lungs and smooths those lungs. I'm sure we're all familiar with doing that, right? Probably give a ton of it here. Do you notice a combination of a bronchodilator and an anticholinergic? So you have the effect of, again, dilating the airway with the beta-2 agonist. Again, depositing in the airway that anticholinergic, which is going to reduce what? Okay, it's going to eliminate that effect of the neurotransmitter acetylcholine, which causes what? The bronchoconstrictor, right? Okay, then inhaled corticosteroids. So again, I'm sure we've got patients on fluconase, other corticosteroids, right? Okay. Now, how many of you, when you give your MDIs, encourage your patients to rinse their mouth out immediately? Do you? How many of you actually routinely do it? With all MDIs, right? What's going to happen with those MDIs if you don't do it? Because of thrush, right? That thrush, that fungal infection of airway, it's going to cause what? Problems down here. It's going to increase that asthmatic effect, right? That's going to be an extrinsic and intrinsic factor that's causing that asthmatic effect on my COPD patients. If you're getting MDIs, you need to make sure that you are having the patients rinse their mouths routinely after every MDI engagement, okay? Please do that. If not, you're going to cause the patient to begin to lean towards an exacerbation more frequently. Last thing you want to deal is with a fungal infection or thrush. Okay, we talked about combination therapies. Again, we're going to look at that, doing that. We talked about that. For sure, I take long-acting bronchodilators and our corticosteroids. Exacerbations. And just get to reinforce with my treatments. You give an aerosolized drug, something that is very important. One, particle size and airflow. If I don't have enough airflow to get that drug deposited in the airways, it's meaningless, right? I can give a patient 30 nebs. If I can't get into the lungs, it's not going to work. So airflow and particle size is critical. So my patient that has an MDI ordered, particle size is optimal. They give that good airflow, meaningless. How many of you give MDIs with a spacer? You don't routinely, do you? Odds are that my patient who has emphysema or bronchitis doesn't have enough airflow, or it's impaired enough, that without that spacer to allow the medication to collect and gather here, give them time to get that deep breath in, do breath hold, medication's not actually making it into the upper airway, the oropharynx, which means it's meaningless, right? Which means that in 2 hours, if we say I'm short of breath, and you're going to go back and give another MDI, right? It's not going to work, right? Plus, on top of that, where's all the medicine end up at? Oropharynx, right? This will cause the potential for what? I just talked about it. Thrush, right? All right, so again, compromise the patient in two fashions. One, not depositing medication where it's effective. Second, you're putting them at risk for a fungal infection, which will cause what? That asthma component to kick in, right? So again, I can't tell you how many asthmatic patients I've dealt with that's just been typically poor performance of metered dose inhalers. And if I'm the one giving the metered dose inhaler, whose shoulders the rest on? Me, right? So again, please keep in mind, if a patient can't perform this well, get a spacer. If you're the one delivering it, make sure you're getting the rinse your mouth out after every MDI engagement. Okay, oxygen management. Okay, we know oxygen prolongs life. Hypoxemia or lack of oxygen uptake can increase mortality at a faster rate. Okay, oxygen can add 5 more years to life to have severe COPD patients with severe hypoxemia. But the rules are critical for oxygen use. With poor gas exchange, I give a patient oxygen, but if they can't blow off the CO2 that's produced by the body as a result of taking oxygen, I'm going to compromise the patient correctly? Correct, right? Okay. So again, going in and turning on a patient's oxygen because of short breath is not the right answer. Now typically what I run into in this environment a lot is Bob's short breath, so we're going to crank his oxygen up. His sats are going up to 90, so he must be better now, right? All right, so again, but again, that increased CO2 production, you're not taking that into consideration. So again, let's talk about assessing the patient. Here's where we start messing up with our patients. 5-point assessment. Pulse oximeter on a patient, at least 3 minutes to get a good reading. If you pulse ox on a patient and you're taking that reading in 30 seconds, you're not getting a good reading. It's not accurate. 3 minutes for a good pulse ox assessment. Okay, 3 minutes to get a good average. Now again, I'm sure that a lot of you put the pulse ox on the patient, and when you're doing your CNAs or you're doing the vitals or writing down the pulse too, right? That's fine and dandy, but can you tell me that pulse was thready or bounding? No, you can't, can you? If they get peripheral circulation, you can't tell me that. So again, pulse ox are great tools, but they're just a tool. They do not replace human touch. So again, you need to make sure that you are touching the patient, taking manual pulse. Watch your respiratory rate. Again, count the respiratory rate. The workup breathing, is it labored? Are they using accessory muscles? If I've got emphysema, if the patient's got emphysema, can you see them get their neck muscles that flared? Again, they have nasal flaring. Are they really working to breathe? Breath sounds. How many of you carry a stethoscope with you? Okay. How many times are you actually putting out on the patient to do breath sounds every time you engage patient?
Not every time I engage the patient.
Well, I mean, to give them a breathing treatment or if you're doing your documentation for PDPM requirements to make sure the building's reimbursed, you need to be doing that pre and post assessment every time you give a NEB or an MDI, right? To make sure the building gets reimbursed. But other than that, it's good clinical care. Can my breath sounds change in 5 minutes? Absolutely right. Especially if I have issues with right side heart failure, right? We've all heard about CHF, right? Okay, again, my patient has COPD and prone to right side heart failure again. Regards to decreased development, just related to his bronchitis. Again, breath sounds related to right side heart failure is critical. So breath sounds with every patient engagement is just good nursing and good RT work. Absolutely, yeah, go right ahead, please do.
On breath sounds, if you're not familiar with what you're listening to, I recommend you either go to Lichtman Library or 3M Library. And they have a very extensive list, both heart sounds and lung sounds. And when you click on the particular lung sound that you want to hear, you'll notice the graphic will actually show you as it's moving through inhalation and exhalation where you should hear what in a particular lung sound. So I highly recommend, if you're not familiar with all your sounds, spend a few minutes on either one of those two websites.
We have a sample of one of those websites in your manual as well, in your handbook we gave you. Now, how many do you have to call the doctor in the middle of the night for somebody in exacerbation? I see a lot of grimaces right now, so I see two here, right over here. All right, now if I'm a doctor and you're calling me in the middle of the night and you said Bob's exacerbated, Bob's having trouble breathing, I want to know these 5 things. What's my pulse ox reading? What O2 are they on, if they at all? Second, how's their pulse? Is it bounding? Is it threading? I mean, because I'm concerned about the heart function right now. Again, how hard are they working to breathe? Okay, again, they've got a lot of accessory muscle usage. Their posture's poor. They're leaning over. I'm looking at the intercostal, the extrathoracic muscle use, neck flares, nasal flaring. Again, breath sounds. Again, pulse ox reading. Okay, and again, that pulse ox reading, how long does it take a good reading?
3 minutes.
3 minutes, right. Less than 3 minutes is not accurate. Okay, so again, we have to manage exacerbations before they happen. We need to make sure that we have those emergency use beta agonists ordered. Your PRN. That could be my inhaler, could be my NEB treatment, whatever is needed. Make sure that we have, again, those other maintenance drug therapies. Again, my inhaled corticosteroids, my adjuvant, my anticholinergics, antimuscarinic agents that inhibit that bronchoconstriction neurotransmitter, acetylcholine, steroids when applicable. And please do not be afraid to tell your doctor or ask your doctors about patients that have frequent exacerbations for oral steroids. Because in today's world, in this environment, the frequency to order a inhaled corticosteroid, again, my patient's impaired, poor airflow, lots of secretions, are those drugs will make it to where they need to get to be effective? No. So maybe they need a salmeterol injection, or maybe they need that oral steroid to reduce that inflammation, to decrease risk of breathing. Antibiotics when appropriate. So again, we order one more thing on antibiotics. We order a broad spectrum of antibiotics like we give out Pez candy at Halloween. Bad thing about that is now we have a whole range of antibiotic-resistant disease states out there, right? MERS is a great example, VRE. So again, please not be afraid either to ask your doctors if they want a culture when they order an antibiotic. To make sure that, again, 24 hours you know exactly what you're treating. They can make sure they're ordering the right antibiotic to treat that infection. That limits the amount of antibiotics we're actually giving these patients to make sure they're useful in the future. And secondly, most importantly, make sure we're actually treating the right infection, right? So do not be afraid to ask for a culture or recommend it. The most important modality you can perform today to these patients is cough. So again, we'll talk about cough in a minute when we talk about bronchial hygiene. Oxygen management, especially during ADLs. Getting patients to perform their ADLs may be as simple as getting the right orders for their oxygen. Ray mentioned earlier in one of the presentations about getting an order for titration for O2. It could be to order a titration order for O2 between 2 and 4 as an example. During ADLs, during bathing, during ambulation, to maintain stats above whatever the baseline is. Now, who can tell you what a good SAT reading is? What a baseline SAT is, what it should be?
92 to 95.
Why? How do I know that?
So are you speaking as in a patient with COPD?
Yes, in general. What's a good SAT reading? What's a good baseline SAT reading, and why?
Well, we was told anything 94. In school, they told you this.
Depends on the patient.
Depends on the patient, right. My baseline depends on the patient, right, historically. Bob may function at 88 and be perfectly fine. So you're going to check Bob at 88, he's fine.
Actually, I'll be freaking out.
Well, you shouldn't.
And
Again,
this is like COPD, everyone has to probably pass out.
huh?
I said, this is like a COPD patient, or this a norm. 88 for me is like something is wrong where I have to do something.
Well, again, it goes back to your patient. Again, you have to look at the entire patient. Your baseline pulse ox reading should be patient-specific, not a generalized reading. So again, remember your patients. Again, looking at them historically, what their baseline. The baseline should be based on the patient. If I'm looking at 95, for some patients 95 is not unnecessary and unachievable. So it could be for some of my COPD patients, 88 is the perfect number for them. Some of my COPD patients could be that when they get to 86, 84, that's when I start worrying, or 80. But I know that I can get Bob back to 88, he's fine, or 86, he's fine. So baseline is, for my patient, is patient-specific. There is no generalized baseline for patients. It's patient-specific. You know your patients.
You could have a COPD patient that's a CO2 retainer,
Right.
and you start getting his SAT at 95 or greater, he's going to start becoming lethargic.
That's right. Remember I mentioned CO2 narcosis? He's going to be obtunded. He's going to be...
Right.
Right. So again, more is not better by any means. So I don't think just because you're cranking up the O2 and it's set to 98, you may actually be doing more harm than good. So baseline is based on the patient's historical average. Okay, so again, keep that in mind. So my question again is, what's a good baseline? Can you give me one? You should not be able to give me one. Baseline is patient specific. Okay? Okay.